I am going to wrap up by talking about some work that has been done by the Family Planning National Training Center, the FPNTC, on behalf of the Office of Population Affairs in the United States, which of course is responsible for the Title X program of family planning clinics in the US. And I'll be telling you much more about some of the resources that we've developed toward the end of our conversation. Next slide. So for all of us, as you've been hearing this morning, our overall goals for care are really a balancing act. On one hand, you've heard over and over the sense that family planning services are essential health services, and what we want to be able to do is to continue to provide the same very high quality, patient-centered contraceptive counseling, a range of contraceptive methods, and so on to our clients or patients in the way that we always have done that. But on the other hand, we have to respect the physical distancing rules that are mandated from a public health point of view during the time of the emergency. So obviously the sort of prime directive here is to avoid unnecessary staff or patient exposure to the virus that ultimately could lead to illness. Second is that we want to make sure that clinic visits are available to see the highest priority patients in person as that's necessary. Third is the fact that we have to make sure that we have the capacity to absorb staff shortages, because a staff member might be sick, one of their family members could be sick, they could be in temporary quarantine and not able to come to work, or for that matter, their child's school might be closed and they're not available to come into work. So we have to be able to expand or contract our in-person capability based on the availability of our staff members. And then lastly, we have to be very clear about not only all of our messages regarding family planning, as we've been discussing, but also our understanding of the SARS-CoV-2 virus as well as COVID-19 infections, so that we can educate our patients in that regard. So on one hand, we want to be as open as we can to provide high quality services, but on the other hand, we're trying to balance that with protecting our staff and our patients. Next slide. So as you've been hearing a number of times, and I'm sure you knew this anyway, that there has been this incredible acceleration of the movement toward telehealth services in the world of family planning. And obviously that's something that has been going on for years. There are a number of family planning systems like Planned Parenthood of Maine that have been doing telehealth services as I said, for years and years, and there are at least 12 different proprietary companies which are app-based for people to be able to get their contraceptive methods by telehealth interactions. But we did a poll recently on one of our Title X webinars asking whether or not clinics had actually switched over to providing services by telehealth, and almost 90% of family planning clinics in the Title X network are providing either some or all of their services by telehealth. Next slide. So one of the decisions that every clinic system needs to make a decision about is deciding in advance which services you're going to try to do remotely as opposed to those which necessarily need to be done in person. And off to the right, you'll see an example of a prioritization scheme that the Family Planning National Training Center is offering. Don't have to be a member, it's freely available on their website. But one of the things that I want to be able to stress about these prioritization schemes is the fact that they have to be fluid. Your staff might meet as frequently as weekly to decide which services you're going to do remotely and which are going to be done in person. That's going to depend on your local or state physical distancing laws, the availability of staff, again, because of the fact that a fair number of staff members may be not able to come and work in the clinic, and the personal protective equipment that you have available, and also whether or not you're utilizing curbside pickup or mail delivery of contraceptive services. Next. So here's an example of that kind of triage or prioritization template that you might think about putting together. The first column being the types of visits that can be postponed until the time that the public health emergency is at least over with temporarily, because it could come back certainly. The next column are issues that can be handled entirely by telephonic conversations, and many of these are billable visits, by the way. The third column has to do with formal telehealth visits that for most payers mean having both an audio and visual component, although there are a growing number of payers, including Medicare, that actually will accept strictly a phone call as a billable visit rather than necessarily having the video component. So be sure to check with your various payers about whether or not the video capability is expected or not when you bill for those visits. But obviously there are still those services that need to be done in person in relation to intrauterine contraceptives, to some degree DMPA-IM, although that could be given curbside, as some clinics are doing, and then services related to IUD placement and removal. Next slide. So the reality is that a majority of family planning providers in the country are in fact making IUDs and implants available. The last time we surveyed that, again, with the Title X audience, is at about 60% of Title X providers, at least that tuned into our webinars, are still providing IUD and implant services on site. And we also have found that most are relying on CDC guidelines to make decisions about what to do during face-to-face clinical visits, as well as integrating their local, regional, statewide, and national public health emergency policies. Again, something that might be quite fluid. Next slide. You also heard Dr. Dean mention the fact that ACOG has also come out and made a very public statement, fortunately, on their website about what they consider to be the priority of continuing to provide LARC services during the time of the public health emergency. And I quoted them just because I thought it was very nicely stated. The ability to obtain or continue contraception improves reproductive autonomy, reduces unintended pregnancy, and profoundly affects a person's life, health, and well-being in times of stress and financial hardship. As you need to advocate for family planning services being essential services, this is really a nice way of saying it. Next slide. So you've heard earlier about the possibility of patients calling in and requesting IUD either removal or exchange. Removal because they think that the duration of their IUD has been reached, or for that matter, they want an exchange of their IUD. And remember that there are differences in time intervals of efficacy. Comparing the difference between the FDA-approved intervals and the evidence-based intervals. So specifically with intrauterine contraceptives, you can see that with the two longer-acting levonorgestrel IUDs, that the evidence-based duration is a full 7 years. We really don't have enough information yet on Skyla or Kylena to recommend extension beyond their FDA-approved duration. And with a copper IUD, they can be used all the way out to 12 years. You will also see evidence-based durations for Nextmon in the first line and for the variations of DMPA in the bottom 2 lines. Next slide. Now, one of the things that I'm sure you've considered in your clinic is what are the adaptations that we should be making in regard to doing in-person services, particularly as they relate to IUD placements and removals. And this is a collection of the various factors, really variables, that correlate with not only exposure to the virus, but also the inoculum size or amount that a person might come in contact with. And we know that, of course, it's not only a major issue of whether you're contacting the virus, but how much of it also seems to make a big difference in terms of the likelihood that you'll be infected and probably even the severity of your infection. So the 6 factors that we think about are proximity, higher risk if we're in contact with an infected person within 6 feet. Second is enclosure, that infections are more likely to occur when exposure occurs in a small room, particularly with poor ventilation, as compared to a large room with good ventilation, or better yet, being outdoors. The time of exposure to the virus seems to be important. Short exposures are less likely to lead to infection than longer exposures. More recently, we've learned about activity, that activities like singing or very loud speaking increase the risk. And you've probably heard about a super spreader event that have actually happened in a number of different churches related to singing in church choirs, and a higher rate of spread because of that. Next relates to protection, and that is to say that if there's no hand washing, the use of face masks, personal protective equipment, or cough etiquette, then there's a higher risk of infection, while consistent use would lead to a lower risk of infection. And then lastly, the prevalence in the population of people that you're taking care of. Next slide. Now that can be converted into information that you can use in clinical practice. So when you're doing IUD services, try to have as few people as possible in the room and maintain distance of 6 or more feet if possible. Use your largest exam room. Minimize the time the client is in the exam room. Try to limit loud talking, although if everyone's wearing a mask, that's probably a less important feature. Masks for all, that is to say the patient, the person who's doing the IUD services, and other staff members in the room, and then pre-screen for symptoms. And remember, the initial symptoms that we looked for were shortness of breath, cough, and fever. The CDC has added 4 additional symptoms that we should be screening for. Next slide. So the kinds of things that have been done to minimize risk exposure before an in-person visit is remote registration, counseling, and consent. Have the client or patient wait in her car, perform intake through a phone conversation before she actually comes into the clinic, screen for the symptoms I mentioned, and if she has those or other risk factors, delay her procedure. In fact, you might even refer her for testing or medical care if that's necessary. A screening temperature check has been done by some family planning clinics, but seems to be of questionable value because of the fact that it's not very sensitive or very specific, and note that it's not explicitly recommended by either CDC or ACOG. Next slide. Now, in the exam room, again, all staff and clients must wear face masks. Upon entry into the exam room, again, try to use your largest room, especially if it's one that benefits from negative pressure, or if you don't have that, even open a window, and that may help. Minimize support staff and people in the room. Try to minimize moving between rooms, and you all know about monitoring your PPE supply. Next slide. So one last point, and that is about once a person has had her IUD placed, then what about a follow-up visit? Well, what used to be called a string check visit was considered to be optional even before the public health emergency. And the U.S. selected practice recommendations have pointed out that no routine follow-up is needed. They said that more frequent follow-up visits might be helpful with adolescents or people with certain medical conditions. But the point is that those check-in visits can be done by telemedicine, and a person doesn't need to come into the clinic.